So, just a question to the house. Can you tell me when was the term artificial intelligence first coined? Good, 1955. So this is not a new thing. We think that artificial intelligence is something new, but this is age-old thing. 1950 it all started. 1955, John McCarthy coined the term artificial intelligence. Then computers became faster after 1974 when Windows paved its way inside. 1980 again marked the resurgence of artificial intelligence, and there were a lot more researches into artificial intelligence. Previously, the research was only focusing on the inputs given by persons, but then machine learning came into play. And in 2000, the landmark of AI established and achieved, and now we are seeing day by day AI achieving what we have never dreamt of. So this is again a broad history of artificial intelligence. In 2018, the ethics came into it because there were a lot of things with AI, but there was no one to govern this, as Dr. Alok was rightly pointing out. To me, there are 4 industrial revolutions. First was engine, roads, and railroads and steam. We all know about it. Second was mass production, electrical power and assembly lines. Third was electronics and computers. And fourth is right now, artificial intelligence. Believe me, this is the next industrial revolution because the world is going to change in next 10 years or so. You look at the top 10 healthcare trends and innovation in 2024, you will say artificial intelligence, mobile health, Internet of Things, 3D printing, telemedicine, everything related to technology. Because technology is the way forward for any disorder, let alone diabetes. Again, the trend in innovation, when we see AI, telemedicine, Internet of Things, Dr. Rakesh Parikh will talk about telemedicine, and this is again a wonderful thing which will happen to us. Time had to publish an article for this, the future of medicine. And the future of medicine, they said, was artificial intelligence. And if you want to read more about it, there is a book by Eric Topol. You should go and read, and you will know that in 10 years, radiologists will be a thing of past. Now, what is artificial intelligence? Coming back to the topic, it is simply, in a very simple definition, the capacity given by us humans to machines to memorize, learn from experience, to think, to create, to speak, to judge, and to make decisions. So we are creating them, we are feeding them, and then they will be working on their own. Now, these are the various subsets of artificial intelligence. Don't go into deep of it because we are doctors, we are not technology people. Artificial intelligence, as I told you, it empowers machine to take decisions, and machine learning is a subset of artificial intelligence which uses algorithm, which gives that calculative power to that machine, and that is how the machine calculates. Then there is deep learning, which creates neural networks, just like the network in our brain, so that the neural networks are fostered. And then comes generative AI, where we can generate something which no one has generated or which is beyond our capacities even. How we can use this? Machine learning can be used for predictive analysis, deep learning, speech we use in text-to-speech, speech-to-text, vision, image recognition, machine vision. Then we can use NLP, the language processing, for data extraction from our EMR, translation, classification, expert system, planning and optimization of services, and robotics. AI system technically should be able to do 4 things: reasoning, read, understand and respond, plan, and improve automatically via machine learning. So this is the basic difference between artificial intelligence and machine learning. Now, very simple example, how does it works? The problem was to rule out coronary artery disease in a diabetic with doubtful symptom and a normal electrocardiogram. What it does, a doctor, we are training it, mind it, the doctor human teaches the program with the help of a gold standard test. It says yes or no. The machine remembers the response. What happens next? Based on the response given by doctor, next time, the second step is with machine. The AI predicts the condition, and then doctor is again involved when he again redefines the output, whether it is yes or no, and then the fine-tuning and output is done, and machine is learning by itself. Now, in the end, we are gone. Human is nowhere. Machine is doing the thing on its own, and it is computing to the best of its capacities better than us, and without tiring and without any psychological bias. We may be tired in our OPD, we may miss few things, but machine will not. There are 3 broad types of artificial intelligence. First is artificial narrow intelligence, which is just simple machine learning. Machine learns itself. Stage 2 is general intelligence. Machine intelligence refers to computer that is smart as a human. The threat is artificial superintelligence, when machine is much smarter than you and it can overturn you. These are the levels of AI. First is artificial narrow intelligence, as I have told you, general intelligence, and superintelligence. The ideal AI is the green dot, just less than us, the creator. And that is what we want. Let's see the future, what it holds. This is a very beautiful read, Artificial Intelligence, the Future of Care. If you have time, you should go and read. It contains everything you need to know right now at this point of time about the future of diabetes regarding AI. It has a triple play in healthcare. First, it reduces cost because reduce the need for almost everything. It does many of the things on its own. It creates a business impact where, because a lot of healthcare is driven by business houses, so it creates a profitable opportunity for them. And operational impact because operations become much smoother with the help of artificial intelligence. Now, digital health is again a term which comes when we talk about diabetes and machine learning and artificial intelligence. Digital health consists of wearable sensor, like we wear all the time, Apple Watch. Wireless communication is enabled between watch and phone is having a software and a processor where it works in tandem to generate data, to calculate data set out of it and give output. So this digital ecosystem of data-driven tools, it can link people with diabetes and their care teams even. Doctor can be connected with patients, subset of data which are generated all the time. And these are the various data which we can generate with our patient. Right now at this point of time, this many things are available. We can have a, what I will call it, we can have a futuristic patient like this, and he will be flooded with sensors and we will be getting loads of data. But what we will do with this data, because this data is technically known as big data, because it is such big that we are, as humans, not able to analyze it. It comes from wearable device, publicly available data, electronic record, social data. It goes to a digital platform. And with the support of human, it is refined. And then patient-centered outcomes are derived, machine learns itself, and this is how it would be a future digital ecosystem which will pave its way into diabetes management. Now in diabetes, how it can help? It can help in hypoglycemia prediction, insulin management, personalized OHA recommendation by precision medicine, personalized diet, patient education and counseling, and target organ assessment. This is a very common thing which we use, almost all of us use in our day-to-day OPDs, a fundus. This was the first thing which came to our clinics, and it does a beautiful job. There are 2 FDA-approved DR detection systems for non-ophthalmologists. You don't require ophthalmologist, and they are working. AI has proven to be better at image processing, better than us, human vision, because it does better with thermal imaging, tissue density differentiation, dynamic change, flow detection, and all the things. That is why it is better able to detect the foot parameters, even the myocardial perfusion SPECT, and the fundus, even the ECGs are read better than artificial intelligence. In hypoglycemia, this is a app which is saying that I see your sugar is often below target between 12 p.m. to 3 p.m. on Saturday. You might be doing something different at that time. I will keep an eye on pattern. And it predicts the hypoglycemia before its occurrence. This is the Sugar IQ app by Medtronic. This is just by a mobile phone app, integrates with Guardian CGM, and it predicts hypoglycemia 4 hours earlier to its occurrence. Sorry. Now this is again working on pattern recognition and prediction. It is a FDA cleared technology which will warn you that you are supposed to have a hypoglycemia in next 2 hours. So 2 hours is enough a time to eat something. This is how it works. Threshold alert cannot avoid hypoglycemia, but predictive alert can reduce or prevent hypoglycemia, and it keeps on learning on itself, and it predicts and gives you the prompt that you are going to have a hypoglycemia soon. Then the next revelation is closed loop hybrid system, where we all know Minimed 780G has done wonders. We are getting TIR, which we are never able to achieve with all of our efforts, educators' efforts, and patients' effort. It do all the thing, determination of correction boluses even, and it does wonderfully well in our patient. Insulin dose adjustment for patient who are not on pump therapy. Again, this is an article which showed that the decision support system works better, and it gives optimal insulin dosing, and smart alarms are also given based on the patient feedbacks so that they can prevent hypos. This is a revelation. This is an AI-powered digital endocrinologist, DRWA, which is US FDA-approved technology for type 1 diabetes and type 2 diabetes patient on insulin. And it is non-inferior to endocrinologist, generates a prescription in just 20 seconds. This is precision medicine, AI-enabled precision medicine, because we all know even diabetes is now clustered according to subsets, and one medicine which is working good on one patient cannot work on other. So it creates a subset of patient based on which patient is responding well to what. And that is how we will give, and we will be able to give precision medicine to our patient. Personal nutrition. This is a thing where a lot of companies have come up. And this is actually a thing because glycemic index is now a thing of past. We cannot have a same glycemic index for two people. What a banana can do to me cannot do to Dr. Shambhu. So this is something different for each and everyone. And what is done by machine learning and artificial intelligence, it predicts my response to banana and warns me and advises me how much insulin to take, how much exercise to do. This is again a comprehensive patient education behavioral intervention, one-drop AI system, which does wonderfully well, reduces HbA1c by around 2%, 20 gram fever carb per meal, and 35 minutes of additional activity per week by just prompting. Our own artificial intelligence offers significant rate of remission for type 2 diabetes compared to standard care. This is again the study of digital twin, which is from our country, India, and it shows a fabulous result. The change in HbA1c from baseline to 90 days of follow-up, who remained or adhered to the twin precision from 8.8 to 6.9, and the percent of patients with HbA1c in target less than 6.5 rose to 40%. This is my review. You can go and read impact on ChatGPT on enhancing healthcare. It has a tint about diabetes care, how it will be going to impact it. Artificial intelligence again predicts the progression of diabetic kidney disease, and it does much better than any other parameter. And it has again been proven, and it is again gives a negative predictive value of 85% and positive predictive value of 40%. So it is again evolving, and gradually it will evolve so that we can be better able to predict and prevent complication in our patient. Combining AI and footwear, it improves the diabetes treatment, we all know, and this type of shoe would be with our patient soon. This would be giving real-time data, and it will be doing pattern recognition, digital twin model, it would be water resistant, it will give metrics on foot pressure, temperature, pronation, foot strike, where the pressure is there on the foot. It is having a Bluetooth and smartphone connection, so the data would come to your clinic if the patient consent to it, and it has a wireless charging, so that you will be better able to protect the foot of our patient. In this, we can do prediction of foot ulcer, wound assessment if the patient is having wound, suggestion for appropriate footwear would be done based on machine learning algorithms. This is very interesting. The AI model enables earlier detection of diabetes through chest X-ray, and they have developed the algorithm whereby looking at chest X-ray, they will be able to predict the diabetes. One more revelation which it can do to doctors, because it can empower our doctors. And busy clinicians don't have time to read the articles. What it can do, with IBM Watson, you can read 5,000 new medical studies a day and still see patient. This is a revelation, because without knowledge we cannot survive. This is again a very beautiful read, Artificial Intelligence in Diabetes Management. What are the advances, opportunities, and challenges? Because every new technology has its challenges, and AI also has challenges. The downsides of AI are, because AI is only good as the data, because in developing countries we don't have good data, biased data, data quality is the issue. Then the intention of vendors is again a question, and variability in result is there from different AI systems. Training acceptance is again a question in India. But to improve diabetes care, we need more data, because data is king and information is power. And human intelligence needs AI to make sense of huge amount of data which is provided by technology. What it will do, it will predict diabetes, it will select appropriate anti-diabetic treatment, it will prevent hypoglycemia, do target organ assessment, protection, behavioral modification, and quality of life improvement. I just end with this quote of Steve Jobs: technology is the amplifier of our intellect. Thank you. It is just the beginning of AI.
Thank you very much, Dr. Bharat Sabu, for a fantastic talk.
Thank you, sir.
I gather a small takeaway from you, if I have correctly understood, that India is loaded with a huge burden of diabetes cases, but with very poor capture of data. And I think using EMR, using artificial intelligence and ML should change that scenario and put us, if we have a concerted effort of capturing data, recording and sharing amongst all of us across the country, I think we'll be at the forefront of research in diabetes care. So.
Thank you. Thank you, sir.
We'll invite you, sir. At the end of the session, we will question answer. If Dr. Mudit is in the audience, please come, sir. So we will talk on impact of big data and predictive analysis on metabolic disease management. Sir, podium is yours. Over to you. Thank you for coming and delivering lecture.
First of all, thank you so much, Dr. Patni and DRWA, for giving me this great opportunity. Now, in continuation with Dr. Bharat's talk, we understand that AI and innovative technology is the future and probably will play a very important role in our day-to-day patient care. Now, the point comes that how do we develop these technologies? And what exactly is the use of these technology? How do we use them? Now, we understand the data and the predictive analysis which these technologies give will be imperative, will be probably a paramount, will be of paramount importance in delivering better patient care, especially in diabetes and metabolic syndromes. And my talk will be on the same. Now again, my talk would include big data and predictive analytics in healthcare in general. Then somewhat about metabolic disease overview, big data healthcare, predictive analytics in healthcare, metabolic disease data collection, analytics of diabetes management. Then we'll understand something about the predictive models for metabolic diseases. What are their benefits, their challenges, some certain successful case studies, the future of healthcare analytics, and of course, I'll be concluding my talk. Now let's understand what exactly is big data and predictive analytics in healthcare itself. Now as you can see in the picture, it includes everything what we have talked about till now. Now big data refers to the vast amount of structured and unstructured data that is generated in healthcare settings, offering valuable insights and patterns that can be used for improved decision making. I'll again say improved decision making, not replacement of our patient care, right? Not replacement of doctors. Now again, this will include our own EHRs, this data which we collect for our patients, medical imaging, wearables, the iWatch which he showed, and of course, genetic data. What does predictive analytics say? So predictive analytics involved using this historical data. So again, using the historical data, statistical algorithms, and machine learning techniques to identify the likelihood of future outcomes, enabling proactive intervention and personalized treatment. Proactive interventions. That means what can we do for our patients? Not just symptomatic treatment, but of course preventing complications and of course treating them before even they come. Now of course an application of this data in metabolic disease management, that includes integration of big data and predictive analytics in metabolic disease management that allows early risk identification, personalized intervention and continuous monitoring to improve patient outcomes and overall health. Now we all know what the metabolic diseases are. So they generally include diabetes, obesity, cardiovascular disorders, fatty liver or NASH, insulin resistance, neuropathy, and kidney disorders. So of course they are all the problems, they are all the ailments which basically reduce us or probably reduce the energy balance that leads to health complications and chronic conditions in general. Now again, the impact on health is grave. So again, they have wide-ranging effects on health, including increased risk of cardiovascular diseases, organ damage, reduced quality of life, and higher mortality rates, making effective management essential for overall well-being. Now, how do we collect these data and what are the sources? So again, there are various metrics and there are various sources where we can collect this data for predictive analytics. So of course, clinical data, that is basically obtained from electronic medical records, data from hospital management systems, image centers, laboratories, pharmacies, and other organizations which provides healthcare services. And again, the physician's free text notes, the genomic data and physiological monitoring data. Even those purchase which the GPs give, they are also data. So again, they play a very important role in making proactive disease SOPs. So of course, biometric data that is provided by various type of devices, which includes weight monitors, glucose level monitors. Nowadays we have AI-based glucose level monitors, which and again corrected glucometers, and they are all biometric data for our patients. So again, financial data that constitutes full record of economic operations reflecting the conducted activity. That basically helps in standardizing economical treatment for our patients. Data from scientific research activities that results in that are results of research, including drug research, design of medical devices, and new methods of treatment. Data provided by patients themselves, which includes description of patient preferences, level of satisfaction, information from systems of self-monitoring of activity, exercise, sleep, stress levels, etc. And of course, social media data and how active our patients are. And there are many forums, there are many platforms which actually push the patients to put these activities on social media by in communities and social groups, which can probably help us in driving more a better patient care and a personalized care. Now, when we talk about their role in healthcare, so again, it plays a vital role in healthcare by enabling data-driven decision making. That means informed decision making. So again, making it more personalized or precision medicine, better population health management, and again, predictive analytics that can drive early intervention and improve patient outcomes. Now, of course, I have already included these sources. So they include EHRs, medical imaging, wearables, genetic information, and social determinants of health, and of course, digital health platforms providing comprehensive insights and patient health and behavior. Now, again, when we talk about any technology or anything, it includes two things: the challenges and the benefits. So of course, the challenges may include, the main challenge is basically making the data available to us because it's all scattered. Right, so the main challenge is that because it is available in various sources, various storage areas, adjusting the data storage, analysis, and again presentation for a clinical setting. So again, it's very different when we talk about in the form which is available, and again when we have to use that data in a simple way for our patient care. Now again, that basically leads to issues with data security, interoperability, data quality, and regulatory compliance. Regulatory compliance, that's the main problem, which it's the ultimate problem which we all face. So again, the benefits include enabling appropriate data storytelling for decision making with low risk and data support, benefiting healthcare stakeholders by ensuring timely personalized interventions, connecting communities involved in data analytics and healthcare informatics, and providing clinical data insights accordingly, and again to provide enhanced patient care in healthcare organization by realizing full potential of data and supporting the entire healthcare system, which includes the payers, the patients, and the management. Now, moving from data to predictive analysis. So again, what is predictive analysis? It's basically the practice of extracting the information from existing data to identify the patterns and predict the future outcomes and trends in healthcare settings. Now, the techniques generally include regression analysis, the classification of the data, clustering the data, and making neural networks and AI by using the same data for better patient outcomes. So again, as I said, it's basically to forecast patient outcomes, identify potential risks, optimizing decision making, and again, personalized treatment strategies. Now, talking about how do we collect and challenges accordingly. So again, efficient data collection from metabolic disease management faces data fragmentation, data quality issues, interoperability challenges, which basically disrupts the whole chain. And the solutions are simple, and we probably know about it. So again, they are standardizing data format, as we see in our EHR or EMR systems, interoperable systems. So the two EMRs can be integrated with each other, and again, they can talk between each other, as you have in hospital management systems or big healthcare settings. And again, data quality assurance processes, the SOPs, which we generally have in our hospitals, our healthcare settings, or in our multiple chain of centers. Now, again, the analytics basically helps in personalizing the treatment. So again, it enables healthcare providers to create personalized treatment plans that is based on individual patient data, their medical history, and predictive insights, which the systems themselves can predict and provide us in a better manner to better patient outcomes. So again, we can have tailored treatment approaches, continuous monitoring, proactive interventions, optimized outcomes, and again, enhanced patient satisfaction. Now, there are certain predictive models which basically works in metabolic diseases. So there are factors which we have to include in predictive models, which includes your genetic predisposition, lifestyle habits, medical history, and environmental influences. And in their development, there are multiple data sources and variables of acute predictors that generally includes the risk stratification, risk assessment, progression, and treatment outcomes for our patients. Then there are certain benefits which we get with predictive analytics. Of course, there are multiple benefits which includes better imaging and diagnostic techniques, early disease detection, providing personalized treatment to our patients, clinical decision support, drug discovery and research, and of course preventing medical and insurance frauds, which are nowadays quite common and of course very common in our Western counterparts. Now, there are certain challenges and limitations for predictive analytics. So again, regulatory challenges, as I mentioned before. So the compliance, that's the problem. So again, there are regulatory frameworks, data privacy laws, compliance standards that present challenges, and legal considerations which we generally face in our patient, less in our country probably, and more in our Western counterparts because of insurance cover. And of course, the other challenges may generally include data privacy, security concerns, integration issues, cost for collecting this data, and of course, resource requirement, which is not freely available in our country, unfortunately. Now, there are certain successful case studies. There are multiple. I would probably point out two. So there was IBM Watson Health and Obesity Management. My colleague over here, Dr. Bharat, also mentioned about it. So again, this was basically to manage obesity using cognitive computing by analyzing vast amounts of healthcare data, which was extracted from their EHR records, lifestyle data, and of course genetic information. So the approach was basically the advanced analytics and AI capabilities of IBM Watson that integrated the data from various sources to provide personalized obesity management, and again implemented that data-driven insights to tailor-make the whole treatment and lifestyle and treatment recommendations to the patients. Well, it was a positive study. So again, it improves the patient engagement by 30%. It enabled personalized interventions, leading to better patient outcomes, and of course demonstrated potential of big data analytics in transforming the whole obesity management in a customized and effective or personalized treatment regime. The second study was done by Mayo Clinic in cardiovascular diseases in diabetes patients. So this was basically, again, usage of predictive analytics in providing better patient outcomes in cardiovascular diabetic patients. So again, this was basically to provide and to develop predictive models that can incorporate patient history, lab reports, and lifestyle factors that utilize big data analytics to analyze and predict cardiovascular risks, provide actionable insights for clinicians to manage and treat diabetes more effectively in their patients. And of course, the risk was again positive, the results were again positive. So again, there was high accuracy in risk prediction, allowing actionable insights, early intervention, and again, it basically led to enhanced patient care through informed decision making. It also demonstrated the effectiveness of predictive analytics in managing various complications, which includes the diabetes and cardiovascular complications in their patients. Now, these are certain companies which generally use the big data and predictive analytics for healthcare, majorly in metabolic syndromes. So Arcadia is basically a data platform that provides organizations through healthcare landscape and actionable insights that make more strategic decisions in support of their financial, clinical, and operational objectives. IQVIA is again a North Carolina-based company that uses analytics, data, and technology so that pharmacy leaders can complete faster and more effective clinical research. And besides that, to provide AI predictive models for better patient patient outcomes. Amitech is again a Missouri-based company that's basically to provide that applies data to the healthcare field for modern day management. Just 1 minute. Modern management for that. And again, Linguamatics is again in data prediction and NLP. So future is positive. So again, it can be used for personalized treatment, fraud detection and prevention, early detection of diseases, robot-assisted surgery, analyzing errors in prescription, drug discovery, and automated image diagnosis. To conclude my talk, so there are three major benefits. So again, healthcare transformation, that's what we are looking at. So again, the predictive analytics in metabolic disease management signifies paramount shift towards data-driven decision-making, personalized care approach, and preventive healthcare strategies. Call to action is basically to enhance patient outcomes, reducing patient care cost, and improving population health. And of course, continuous innovation and integrated advanced analytics will further revolutionize healthcare, making it more efficient, personalized, and proactive for our patient care. Thank you.
Sir, thank you so much. A very big topic. Tried to explain us in your simple way. All those 4 speakers in this session, they will try to keep a step forward, whatever we have learned in medical colleges. Thank you again, sir. I will hand over to Dr. Alok Modi for future proceedings.
Before I invite the next celebrity speaker for today's talk, there is an important announcement. Vice Chairman, as you people have seen, I've already come over here, so there will be a lucky draw in this hall at 11 a.m. So please call all your friends and colleagues. So come down for that draw. Don't miss that draw. It's going to be a very exciting draw. And now it's time to introduce the next speaker who doesn't need an introduction. So if I may say, Amitabh Bachchan doesn't need introduction inside Bollywood and outside Bollywood. So our next speaker is Dr. Amit Gupta, who's a very renowned personality. And today he's going to give us a talk on telemedicine and diabetes care, enhancing accessibility and patient engagement. So over to you, sir.
Yeah, topic was different, I guess. It was CGM.
Oh, I'm so sorry. See, I'm confused. So I'm very sorry. I apologize for that. His topic is glycemic variability.
I thought I prepared the wrong topic. So thank you, dear Alok and Vinod sir and respected chairpersons for the kind introduction. And today I have been given the task by Dr. Vijay Patni and the team DRWA to speak on glycemic variability time in range and its applicability in the management of type 2 diabetes. So I thought I will keep it simple and straight. And to begin with, there can be several reasons for blood glucose changes. And these reasons can vary right from the food, it can be medications, it can be the activity, it can be different biological challenges like sleep, stress, illness, hypoglycemia, dawn phenomena, infusion set issues, multiple things can be there. These are the biological changes, and then the environmental factors, and then behavioral and decision making. So at least more than 40 factors are identified which can affect the blood glucose levels. And we all know that not all the A1Cs, they are created equal. So A1C of 7% in this picture, you will find the 3 A1C, all the 7%. But in one person, the time in range is almost 100%. In another person, it is 63%. While in another one, it is 24%. So when the time above range and the time below range increases, the time in range decreases, and this can also lead to a equally good HbA1c, but which is not a good thing for the patient. So as the glucose monitoring has evolved over a period of time, we have found that CGM captures SMBG may not be sufficient, and because it is not able to capture the different lows as well as highs, and it is not able to give you a continuous recording of the blood glucose parameters. So the CGM is able to capture and provide more than 300 readings each day, and now with the availability of real-time CGM, even more than that. And with the help of CGM, you are able to identify undetected hypoglycemia. At the same time, you are able to identify the undetected hyperglycemia. So glucose variability is not simply is not apparent from the HbA1c, and the glucose variability, it can be intraday variability, it can be interday variability, and it can be a variability over a period of long-term period as well. So this slide shows that the glucose variability may be highly variable, but still the HbA1c can be good. So HbA1c is not a good parameter for the identification of the GV. So how CGM can help reduce diabetes management challenges? If you look at this slide and if you look at the SMBG recordings, you will find that all the SMBG readings are in good range. And even with multiple daily finger stick, SMBG can leave highs and lows undetected. So patient using SMBG could be spending significant time outside of range. So SMBG only provides readings for a single point in time. And this is what happens when you put this patient through a CGM, you will be able to identify the variations which is happening in the glucose levels. So what are the global recommendations? If you talk about the ADA guidelines, you talk about the ATD guidelines, or you talk about whether the ACE or the American College of the Diabetology as well as the endocrinology meetings, you will find that now there is abundant data which proves that CGM can be used in all our patients effectively. And now the debate has moved from the type 1, and now we know that it can be used and applied across all these spectrums of diabetes, irrespective of type 1 or type 2. CGM can be used across all the populations, and this is something which is endorsed by the ADA, ATTD, ACE, and recently the DTEC meeting also had a lot of discussion about the CGM and its applications in people with type 2 diabetes, and not just type 2 diabetes, in different clinical scenarios. For example, even one of the case presented by Dr. Bharat also presented one of the case of CGM in a different setting, not just the type 1 setting. So is there any evidence that supports the benefit of CGM in people with type 1 diabetes and type 2 diabetes? I will not go into the details of these studies, but there are trials which are namely Diamond study, the Gold study, the Diamond 2 and the Replace study. Diamond and the Gold study, they are in type 1 diabetes patients, and Diamond 2 and the Replace, they are in the type 2 diabetes patients. And they have found that if you are able to use CGM in a patient, then use of CGM simply reduces HbA1c in both people with type 1 diabetes as well as type 2 diabetes. So this is one thing which there is a lot of evidence, and it supports the use of CGM where you find there is reduction in HbA1c. Another important factor which happens with the use of CGM is that there is a reduction in the number of hypoglycemic events, and this reduction in hypoglycemic episodes leads to decreased emergency department visits in various studies. So those people who are using CGMs, they have to attend emergency department less frequently than those who are attending it more regular, who are not using a CGM. So this is a slide which is a summary slide where you can identify what are the benefits of improving time in range while using CGM. So there are studies in retinopathy with more than 3,000 patients, and the study showed that each 10% increase in time in range from baseline reduces the risk of retinopathy by 8%. Another study that looked into the parameters of carotid intima media thickness found that another 10% increase in TIR improves CIMT thickness by 6.4%. There are two studies in albuminuria in type 2 diabetes as well as type 1 diabetes patients, and they found that each 10% increase in time in range reduces risk of albuminuria by 6% in type 2 diabetic patient and by 19% in people with type 1 diabetes. We all know that whenever there is large excursion in the glycemic values or the glycemic parameters, the neuropathic pain can worsen, and it can lead to worsening of the diabetic neuropathy symptoms. So CGM, when you use CGM, you actually minimize glycemic variability, and TIR is correlated with painful neuropathy independent of A1C, and glucose variability matrices and risk factors in patients with diabetes. So studies have shown that there can be improvement in the painful neuropathy with decrease in the glycemic variability and improvement in time in range. So many people will ask, is there validation of time in range or the glycemic variability as a parameter? So this slide very beautifully depicts the percentage of people having retinopathy and frequency of microalbuminuria, those having different time in range levels. So those people who have time in range more than 70%, the chances of retinopathy are less than 5%, while those who are spending a lot of time in glycemic variability with 10%, with less than 10% time in range, the incidence of retinopathy as well as microalbuminuria, they are very high. Again, this slide shows that the time in range less than 50% again is a greater risk for complications in people with type 1 diabetes as well as type 2 diabetes, both for retinopathy as well as the microalbuminuria. And also there are real-world portfolio studies, and they found that if 50% reduction in micro and macrovascular risk is associated with a 50% improvement in time in range. So if we are able to improve time in range, there is a significant chances that we can reduce the risk of microvascular complications as well as the macrovascular complications. So the patient who spend more time in range are more likely to experience a lower risk of first major adverse cardiac event, as well as experience less complications such as retinopathy, nephropathy, as well as the neuropathy. So just to sum up, what are the benefits of CGM? It can give good insights into the effect of the food, exercise, illness, and medications on real-time diabetes management. It can lead to improvement in time in range. It can give you different directional arrows, whether the glucose level is having a upward trend or the downward trend. Now with the availability of real-time sensors like Sinocare or the iCan in India, you can have audible alarms for highs as well as the lows. It is approved for children as well as adults with diabetes, and connectivity to the insulin pump. For example, the Medtronics is again completes the ecosystem of the AIDs. So predictive alert for highs and lows can automatically adjust insulin delivery rates. Another advantage is that the CGM tool can be connected with the clinician as well as the family members. So sometime in cases of children, the family members will be aware that what is happening to the glucose levels. And sometimes the clinicians, if they are actively looking into the data received from the patient, they will be able to take timely decisions in adjusting the doses and minimizing the risk of hypo as well as hyperglycemia. Data can easily be downloaded to the clinician's office and reviewed during a face-to-face or virtual visit. Studies have shown there is reduction in A1C, there is reduced absenteeism from work, reduced emergency department visits, reduction in hypoglycemia, and there is improvement in long as well as short-term diabetes-related complications. So these are the overall benefits of CGM. So how CGM can help reduce diabetes management challenges? So this is just a sample report where you can find that this patient is only having 36% time in range, and the target range is only 42%, 36% of the time in high range, and 22% of the time spent in a glucose level which is very, very high. So whenever you are using a combination of A1C plus AGP, combining each patient's AGP along with the A1C, you will be able to change the patient's time in range as well as the time below range, and these two parameters can help in reducing the challenges faced by a person living with diabetes. So this is another important thing. Now you will find in the most of the reports, now they don't have a predicted A1C, they will simply say the GMI, that is a glucose management indicator. And this glucose management indicator, or the GMI, is approximately a patient's A1C using at least 14 days of data. So the mathematical algorithms, they are based on between 2800 to 20,000 plus interstitial glucose values, which are obtained by a sensor during a wear time of 10 to 14 days. As we know, the A1C is based on glycation to red blood cells, while assuming the principle of RBC lifespan is 3 months. While limitations of HbA1c, we all know that it is checked quarterly, does not provide details on acute glycemic excursions, including hypoglycemia. It can be inaccurate and inconclusive in certain patient population. And overglycation can also happen in patients with anemia, and underglycation can occur in patients, those with rapid RBC turnover, such as in those patients undergoing hemodialysis. So this is just to show a report of a patient where the AGP report is generated, and you will find that the time in range is almost 76%. This is a graph which is of a patient, and you will find that this patient is having glycemic variability like anything, and you will find the glucose values being recorded in almost each and every part of this graph. So this patient is experiencing very high glycemic variability, and the glucose levels are not at all under control. And this glycemic variability, we all know that can lead to increased risk of microvascular complications and macrovascular complications. And this happens when you are able to monitor and adjust the treatment. Now you will find that the glycemic variability has come to a very lower level, and this patient was having 93% time in range as of now in the month of January. The same patient in the month today, I downloaded this data today only, and this is still having 86% time in range. So if you are able to look at the data, adjust the doses accordingly, and the patient is able to adjust the lifestyle accordingly, we can get very good results in terms of diet and lifestyle. So what are the benefits for the patient? It determines if patient's glucose levels are within therapeutic goal or not, evaluate efficacy of the current therapy, monitor treatment effectively, safely, help clinicians make insulin and medications dose adjustments, help patients better understand the impact of food, exercise, illness, stress, and medications on the glucose levels. For the patient education, we know that data is neither good or not bad. It is just a piece of information, and it is not a report card. So once, if we are able to identify the bright spots and the landmines, have a conversation with the patient, and you will be able to achieve a better glycemic control. So CGM, to summarize, CGM is a cost-effective technology which can successfully improve one's time in range, reduce hypoglycemia risk, and reduce glycemic variability. CGM should be encouraged within the primary care setting where 90% of all diabetes management occurs. Daily SMBG cost can sometimes be higher than the CGM cost if a patient needs to do it very frequently. Health economic cost benefit analysis have shown that CGM can actually have more benefit over the SMBG, and advanced diabetes technology holds the promise to be beneficial for all the patients with diabetes. So technology provides insight in targeting a rational, safe and comprehensive approach to glycemic improvement, and patients using advanced technology have been able to improve their time in range, reduce risk of and time spent within hypoglycemia, and improve quality of life. With this, I would like to invite you for this World Congress of Diabetes Technology and Therapeutics, which Dr. Rakesh Parekh is going to organize with the team DTech in month of Jaipur. And we have already registered more than 170 delegates for this meeting, which is going to happen in May. Thank you very much.
Thank you, sir. That was again a huge topic, covered very crisply and very beautifully in 15 minutes. You have actually gone into all the nuances and given a lot of wonderful information. Thank you for a wonderful talk.
So it's a privilege to invite the next very dynamic and expert to speak on telemedicine in diabetes care. I very happily invite Dr. Rakesh Parekh, sir. Thank you.
Thank you, Chairpersons, and thank you, Dr. Patni and team DRWA for inviting me to speak on this topic. So, unlike the other speakers, my topic is very short. So, I had to think what to say because to speak for 15 minutes on this topic was difficult for me. I'm sure many of us are using telemedicine. Are there any among the audience who are not using telemedicine or who have not done teleconsultations? Manoj? Okay. So at the end of the presentation, I'll prove that you have done that. So anyways, I'll start my presentation. This is the agenda. So first we'll talk about challenges in diabetes management. What is telemedicine? Then one slide on telediabetology, a new term. And I'll focus more on the ICMR guidelines, which have been released for us to follow when we do teleconsultations. And then some tips from my own experience. So these are the challenges. This was the data which was presented by Dr. V. Mohan in one of the recent conferences. And he said that this is unpublished data from ICMR INDIAP. When they analyzed the data of ICMR INDIAP study, and they looked at the number of people with type 2 diabetes who are achieving the goals for A, B, and C, A being the A1C of less than 7%, B being blood pressure less than 140/90, and C being LDL less than 100, which are little liberal targets. So as per their analysis, only 7% people with type 2 diabetes in India are achieving all the three goals combined. 93% of our people with diabetes, they are still not able to reach the goals which are recommended for them. And the reasons for these are multiple. We know that 50% of people with diabetes, they remain undiagnosed. They don't go to doctor, they don't get tested. Among those who are diagnosed, only half of them are treated and the other half remains untreated. Those who want to get treatment, again, majority of them do not have access to the specialist, largely because the 70% population in India lives in the rural belt where there are no specialist doctors available. And for those who can avail the doctor's facility, it's not affordable because it's all out-of-pocket expenses for most of us. 70% of our people can't afford the proper treatment required for diabetes. There is lack of awareness in our country regarding diabetes, regarding the importance of glycemic control, regarding the complications, how to prevent them. there is a problem with the availability of doctors. We have doctors in the urban areas, but the 70% population lives in the rural areas, and no specialists like to practice in the rural areas. Affordability is a major problem because only 18% of our population is covered by some health insurance, which is a private health insurance, and again that doesn't cover the outdoor cost of their treatment, which is the major cost of therapy. So these are the various factors because of which the care of diabetic patients in India is not optimum. Now, what is telemedicine? So this is a lengthy definition of telemedicine as per the WHO, and the same definition has been put up in the ICMR guidelines also. I'll not read out the definition for you, but in simple terms, we can say that telemedicine is healing from distance. So if you are trying to heal your patient from a distance, that's telemedicine in simple terms. And it's not a new concept. So this slide I borrowed from Dr. Banshi Sabu, and he had this slide in which there is a picture which is published in a radio news magazine in 1924. It's 100 years back. So at that time, this idea was conceptualized that in future there might be something like a teleconsultation where a doctor sees the patient through a radio, checks his temperature, checks his pulse. This can be visualized from that particular photograph. So it was not a new thing. It was conceptualized, but now it's in the the thing that we are practicing, all of us. Now, what are the different modes of telemedicine? So Manoj, you were saying that you don't do telemedicine. Now, text messages is also telemedicine. So if you are giving some advice to your patients on text or WhatsApp, or if you are giving advice to your relative on an audio call, that's also telemedicine. So as per the definition, any advice that a doctor or a RMP gives to a patient through text-based modalities like SMS, WhatsApp, email, or audio call, or video call, whether you use Zoom for that, or FaceTime for that, or whether you use a professional application like Practo or any other Librate or anything like that. So these are the different modes of telemedicine, and they all fall under the purview of telemedicine as per the ICMR guidelines. What are the advantages of telemedicine? It makes the services accessible to people because anybody sitting in a remote area, in a rural area, can have access to a specialist doctor like Manoj or Dr. Rajiv Chawla in Delhi and Mumbai. So that was not possible earlier without the help of telemedicine. Availability, now anybody can avail the facility of a doctor, whether it's available in the city or not. It makes it more affordable. So rather than the cost of consultation, the large amount of money was spent by people for traveling to the doctor's office, in which they would also lose their wages for that day. So that can be saved, and that is how it makes it more affordable. Remote monitoring is now possible, so you don't need to ask the patient to come every time to your clinic. You can remotely monitor them for their parameters and can improve the follow-up of the patients. And overall, by doing all these things, the quality of care that is provided to the patients is improved, the quality of life of the patients is improved. So I just saw this slide somewhere when I was looking for telemedicine and diabetes. So there is a term called telediabetology, and just the same thing, but the different aspects of the care that we provide to our diabetic patients. So something like retinopathy screening, food assessment, remotely monitoring the CGM, advising the patients on CSI protocols, CGM protocols, looking at their glucose diaries, adjusting the therapy, the insulin dose adjustment, the OH adjustment, all those things, and having the data from the wearable devices uploaded on the EMR and then telemedicine. So these all encompasses the term that is telediabetology, which is telemedicine specific for diabetic patients. Now this is the important part. Probably many of us who are practicing telemedicine may not have read this. I had to read it because I was supposed to speak and there had to be some material. So I went through ICMR guidelines, and it's a huge document. Now, as per these guidelines by ICMR, the telemedicine or the teleconsultations are divided into different types. So based on the timing of consultation or the timing of the information exchange, it can be real time. If you are speaking to a patient over audio call or a video call, if you are chatting with a patient on WhatsApp, it's a real time consultation that is happening. The other one is asynchronous, where the patient sends you an email, you reply back to patient after a few days. That's asynchronous teleconsultation. The purpose of consultation, and that has been defined extensively in these guidelines. So the first consultation is the when you are seeing the patient for the first time, or you are seeing the patient after a gap of 6 months. Even if you have seen the patient earlier, a year back, and if he's coming back to you for follow-up, that is again considered as a first consultation as per these guidelines, and it matters because there are different guidelines for first and follow-up consultations. Also a patient who has been seen by you within last 6 months, but if he's coming for a new complaint, which is not related to the prior condition, then again that qualifies to be a first consultation. Follow-up consultation is the consultation of a patient who has been seen by you, comes back to you within 6 months for the same complaint or the same condition. And emergency consultation, as the name suggests, is for any emergency condition, the patient consults you. Then, based on the individuals who are involved in the consultation, it can be a consultation between a patient and a RMP. RMP means any doctor. It can be a caregiver to the patient. So patient might not be in a position to consult you or speak to you, but his caregiver who is staying with him consults a doctor for the patient. That's a caregiver to RMP consultation. Sometimes a RMP who is a general practitioner in a rural area might want to consult a specialist for his own patient. That is a consultation between RMP and RMP. And sometimes even the health workers like the ASHA workers or nurses in the rural areas might want to provide the consultation from a specialist to their own patient, that is health worker to RMP. So these are the defined varieties of consultations as per the ICMR guidelines for telemedicine. What are the key points? It's a lengthy document, so I just thought of putting up some key points here. First thing to understand is that all the provisions of NMC Act which apply on us when we are seeing a patient in private or in person apply to a telemedicine or teleconsultation also. So even if you are giving advice to some relative over a phone, which is a medical advice, that will qualify as a teleconsultation, and you are supposed to follow the same guidelines that you do for your patients. So you must maintain the same standard of care as you do during the physical consultation. And also you must keep the record of all the calls or the teleconsultations done by you, also all the data received from the patient, the data exchanged, the prescriptions given. So these are to be maintained, and these are responsibilities. So as a healthcare provider, we must understand that a teleconsultation is not something which can be taken lightly. You fall under the purview of all the NMC provisions, and if you make any mistakes, you're liable for punishment. So just to give an example, I personally don't talk to patients over phone. I never do that since my early days. Since last 15 years, I never share my personal mobile number to a patient, and the reason is the same. Because anything that you advise to a patient over the phone, he can pull you to the court of law. He can just say, Dr. Saab, I'm not feeling well, I am having anxiety, or I am feeling sweating. You might feel that it's hypoglycemia. You tell him ki sugar kha lijiye. It might be MI, and his son might sue you in the court of law that why do you tell the patient to go to the hospital. So it's better to not consult patients over telephone or WhatsApp, and they are not even paying you for that. So that's why I avoid doing that thing. And then there are some points or some responsibilities which are of the patient. So one important point is that these consultations should never be anonymous. The doctor and the patient must know each other very well. So if you're not sure, you should ask the patient about his identity, his email ID, his phone number. You can verify those by sending the OTPs through the different apps which are available. The doctor has a choice to choose the mode of consultation. A patient might want to consult you only by audio. If you feel that his condition requires a video consultation, you can insist that I want a video consultation, else I'll not consult you. So that is your own choice. The consent is implied if he's calling you, or if the patient is booking a consultation with you, then you don't require to consult because it's implied consent. But if you are initiating a consultation with a patient from your own end, then explicit consent is required, and that must be taken from all the patients. And it is the responsibility of the patient to provide all the accurate information. If the information provided to you by the patient is not correct, then you are not at fault. So these are the key points from those guidelines. Then these guidelines also give different categories or different lists of drugs. So there are 4 lists of drugs as per the ICMR guidelines. List O basically includes all the OTC drugs, over-the-counter drugs like the drugs for fever, cough, all those things. And these can be prescribed to any patient in any mode of consultation, whether it's audio, video, text, or whatever, whether it's a first consult, follow-up consultation. Drugs which are available OTC for common ailments like fever, cough, these things can be prescribed to the patient. The other list is list A, and this can be prescribed during the first consultation only, which must be or preferably should be a video consultation. So this list includes the drugs for treatment of hypertension, diabetes, and other conditions, and these drugs cannot be prescribed to a patient without doing a video call. Then there is a list B, which is a list of drugs which can be used for follow-up patients. It can be up titration of doses or addition new drugs. So these are the drugs which are in the list B. And there is a category of prohibited drugs, which includes the drugs from the Schedule X and the other drugs like narcotics, which cannot be prescribed to any patient on teleconsultation. These lists we must be aware of, because by mistake, if you prescribe something like that over a teleconsultation, again, that's a mistake on your part. And then there is a flow of consultation process also, which has been decided by the ISMR. These are the guidelines. I'll rush through the slides. So the patient can choose the mode of consultation. Then you identify the patient. Consent is implied if the patient has approached you. Quickly assess if the patient requires any emergency assistance. If so, you ask the patient to go to hospital. If you feel that the patient doesn't require any emergency management, then you can do the detailed evaluation of the patient, ask for as much information as you want, and then based on that, you decide whether the patient can be managed via teleconsultation. If yes, then you proceed. Otherwise, ask the patient to come for a physical follow-up.